So basically neovascular glaucoma is a very important entity because you can save sight of a patient if it is rightly managed. And one of the most important causes of neovascular glaucoma in our country is the one that occurs after vascular occlusions, which again occur because of high pressures and especially angle closure. The other most important causes are diabetic retinopathy and CRVO. So this is a classic picture of a neovascular glaucoma where you can see an ectropion UVA and there's a high intraocular pressure. But at the same time, there could be very subtle signs which you can pick up in, let's say, a patient of proliferative diabetic retinopathy. Sometimes there could be a universal sheathing of the entire iris with new vessels. And other cases, there might be just a uveitis with very few vessels, which could also be a masquerade to some underlying malignancy like leukemias or even a retinoblastoma in a child. So when you pick up a neovascular glaucoma, as I said, the most important causes are either a CRVO or a diabetic retinopathy. If it is a CRVO, the ideal thing is to treat the retina. If it is a diabetic, again, you have to treat the retina, but you have to do a PRP which is more aggressive. However, with the upcoming of these anti-VEGF agents, the paradigm for treatment of neovascular glaucoma has changed. We no longer wait for the effect of the PRP to occur. We go ahead, we inject Avastin either intracameral or intravitreal and reduce the intraocular pressure and try to achieve that either through medical therapy or through surgery, and if that does not happen, we can do a cyclodiode. So the treatment for neovascular glaucoma is give intravitreal or intracameral anti-VEGFs and bring down the intraocular pressure either with medical therapy. If it does not get controlled with medical therapy, which most often occurs with angle closure eyes with neovascular glaucoma, you go ahead and do a trabeculectomy. And that can be sight saving for these patients. You then wait and do a PRP at a later stage. So this is what happens when you give intracameral Avastin. You can give it intracameral and the next 24 hours or maybe after 2 days, 48 hours, the entire new vessels have disappeared. The intraocular pressure itself may come down when you do a paracentesis and inject Avastin. Sometimes when you inject Avastin, there is some amount of fibrosis that may occur, but this is the algorithm for treatment of a neovascular glaucoma. You give Avastin, when you see a neovascular glaucoma, do a trabeculectomy. In some cases which are refractory or probably have had a trabeculectomy, you can do a glaucoma drainage device, and in eyes who have no potential vision, you can even think of a cyclodiode. And once the IOP stabilizes, then after 3 or 4 weeks, you can go ahead and do a retinal ablation. So this paradigm for treatment is different from what books. And most of the authors have said that a cyclodiode may be inferior to a TRAB or a GDD. Why? Because a TRAB or a GDD, that is a glaucoma drainage device, will produce a conduit through which the VEGFs can go out of the eye. So the recurrence of neovascularization will be much less if you've done an Avastin followed by a TRAB rather than Avastin followed by a cyclodiode. So you understand, if you have made a hole in the eye through which the VEGFs are going out, the chances are that the recurrence of that neovascularization will be much reduced. And I have seen that many of these patients, you never ever get to see a recurrence of the neovascularization later on. The IOP remains well controlled, the VEGFs are going out of the eye, and the eye never has a neovascularization. But at the same time, I must say that the retinal ablation is essential. It's not that you don't do the retinal ablation, you still have to go ahead and do a retinal ablation, although it can be delayed. So you have to treat as much of retina as possible if the media is clear. If the media is not clear, you go ahead doing an anterior retinal cryopexy, or if you do not have that and you have a diode laser, you can use a diode laser and do it in a posterior fashion. So you can combine intravitreal or intracameral Avastin, you can combine it with PRP at a later stage, but whatever you do, the ideal is first treat the glaucoma and then treat the retina. As I said, trabeculectomy has to be combined with antimitotics, and a glaucoma drainage device is equally effective, but cyclodiode should only be restored for those cases which are refractory. And there have been comparisons where they have compared cyclodiode, that is diode laser cyclophotocoagulation, with glaucoma drainage devices, and some studies have shown that one is superior to the other, but more or less they are equivalent. There are a lot of post-operative complications you can encounter in surgery in these patients, and one of the most important is failure. So it is known that failure of a trab is much higher in neovascular glaucoma eyes, and many of them might require a glaucoma drainage device at a later date. There is a progression of the cataract, there could be retinal detachment, there could be vitreous hemorrhage, which could be related to the surgery but may be related to the underlying pathology itself. And of course there could be recurrent hyphemas, and sometimes the eye may go into atrophy. Anterior retinal cryopexy was once done very frequently in eyes which did not dilate well, and you could not do a retinal photocoagulation, and you must know how to do it. You apply 8 spots of cryo for 8 seconds in the posterior part of the posterior to the pars plana, and try and complete the entire 4 quadrants. But you must understand that it is a painful procedure. There could be a lot of chemosis, and more or less people have given it up and are now switching it over to doing a diode. So to summarize, that neovascular glaucoma is a medical emergency. It should be considered as a medical emergency. The glaucoma should be treated, and should be treated aggressively to save vision of the patient. You can get very good vision. 618 patient has come with neovascular glaucoma. You do an aggressive treatment and patient can even gain vision. But if you delay treatment, that 618 within 2 or 3 weeks will go on to hand movements. Trabeculectomy with mitomycin is still considered a better option, and it leads to a lesser recurrence of neovascularization of the iris, and only if that fails should other procedures be considered. A glaucoma drainage device in case the patient has potential vision, and a cyclodiode, of course, if the visual prognosis is poor. Thank you.